Now we will invite Michelle Neblett of Boeing and her panel to come up and talk about what this means for employers. Come on up. Remember to hold the mic like that.
Thanks so much, Sarah. Come on up, panel. Yeah. It's great to be with everybody here today. We're going to have a conversation as employers about direct primary care and what it means going forward. So today I'm joined by Dylan Landers-Nelson from the Business Group on Health, Linda Brady, my colleague from Boeing, also here today, and Dave Krysiak from Pennsylvania, who's a business owner and entrepreneur in this space. So welcome all, and thanks for being here today. To get us started, I thought maybe we'll have each of you introduce yourselves, gives you a little bit of background about how you got into this space, your interest in direct primary care, and why it's so important to each of your companies, or in your case, Dylan, your organization, your employers.
Sure. As you heard, I'm Dylan Landers-Nelson. I work for Business Group on Health. We're a nonprofit member association based in DC. We represent about 450 member companies, the vast majority of which are large self-insured employers, including a little over 70 of the Fortune 100, including Boeing, and a couple hundred of the Fortune 500. So very large corporations who collectively provide benefits coverage for over 60 million people. I've been there for 11 years, and for most of that time, I have led the work that Business Group on Health does related to value-based purchasing and engagement with the healthcare delivery system. I think the exciting thing about DPC, which is something that our organization has advocated for as well for a number of years, is I sat on stage with Linda a few years ago, not far from here, and we talked about how when you have primary care that provides a great experience, people will come. And we're in a position now where we're removing some of those barriers for people to actually access primary care with a good patient experience that doesn't stink. So that's me, and I'm excited to be here.
Hi, everybody. Can you hear me okay? Linda Brady. I'm with the Boeing Company. I'm part of our healthcare strategy team. I'm based out of Chicago, but we've got locations across the United States. I believe we're in every state. We have an employee in every state. We've been doing value-based purchasing and care for quite a long time, over 10 years now. We started with ACO partnerships, working directly, doing direct contracts with health systems around the country. That's proven to be really valuable for us and for our employees. Those agreements were all centered, interestingly enough, around quality metrics that primarily are primary care focused. And what was interesting is that this became quite a struggle and a hurdle for our health systems to address, because one thing that didn't change was that we were still doing primary care on a fee-for-service basis. So we started making the pivot to primary care, paying attention to national data. We were also watching the behavior pattern of our members, especially our members in the high deductible health plan. Were they using care? It tended to be our healthier people at first enrolling this. They actually weren't getting care. They were opting not to get care, whether that was because the deductible was so high, but the options were few. But one of the other challenges was access. So when you're in a fee-for-service model, when you're chasing revenue, what happens is there's a crunch in terms of people getting access to care. They have to wait. The average wait time right now in one of our markets is 6 months to schedule an annual physical. And that's ridiculous. And part of it is because of the fee-for-service model. So we started partnering in a couple markets with direct primary care partners. In one location, we built a clinic. We actually launched it last summer, and we expected to have about 10% of our members using that after a year and a half. In 5 months, we were over 10%. I think what you said, Dylan, if you build it, they will come. It's the right experience. It's making sure that you have vetted, high-quality providers delivering the care. You are not paying on a fee-for-service model, and you are making it easy for people to get in and get care almost on demand. We also ask our partners to do a variety of different care as well. Our definition of advanced primary care sometimes differs from others' definitions, but for our workforce, it's really important that we stick to this model, and it's working. People are coming. One of our challenges doing this work has been the HSA issue. Our people who have to meet a deductible first, it requires an employer to create an additional administrative pathway if we want those members to also use this benefit. And so we have to create, we're paying the direct primary care partner direct, but we still have to connect them to our insurance plan so we can monitor the deductible and make sure the deductible is met. It is a significant burden, one that our health plan partners have helped us solve, but it was slow in making that happen. Regardless, those in our high deductible health plan are still reluctant to pay for care. And so they weren't using it in the same way that our non-high deductible health plan members were using it. So this is significant for us to see this change. It means that our employees are going to be getting care that they previously haven't been able to get care. And the results we're seeing are astounding. We started in Mesa in 2018. We've seen a dip in specialty use in terms of specialty care. We've obviously seen a dip in ER utilization. These are early results. We're doing more actuarial studies with larger cohorts, which we think are going to be more significant. But my message to other employers is, I think somebody on the earlier panel said, this is going to become the norm. Do this now. I don't know why anybody would be waiting to do this. It's made such a significant difference for our members who are using it.
Thank you and good morning. I appreciate the opportunity. Thank you for the invitation. Pleasure to be here with you guys this morning. My name is Dave Krysiak. I became an accidental DPC entrepreneur, I suppose. I own a couple companies nationally, and I kind of fluked into a DPC membership in 2020. And I got to know my doctor really well, and the experience was extraordinary. And we had a pretty frank discussion. I told him, kind of my business history and everything. And I said, look, I'm not trying to be offensive, but why are you guys not taking over the world? Like, this is unbelievable. It's so different from anything I've ever experienced, and the pricing's right. We're not talking about a concierge level, multi-$1,000 commitment. I don't get it. Help me understand why. And he said, well, he's like, I can only speak for my own panel, but I find that I have a lot of people that can't afford insurance at all. And so they come and they can afford, $70 a month, so at least they get something. And then I also have the other end of the spectrum, people that are relatively wealthy, and so they have insurance and they use it as an add-on because they want the service, they want the access, all the things that DPC provides. And so, being an entrepreneur, light bulb went off, and I just said, hey, that sounds like a huge opportunity. Why is DPC not penetrating the middle market? Why is the middle class not accessing it? How come there's nothing out there for them? And we continued the conversation, and I came to the conclusion that, I own several businesses with a couple hundred employees, and said, all right, let's just build the product. Let's build it for us. And so he helped us do that. And what came of that is a business called Doctor Delivery that basically sells an insurance product that comes embedded with DPC memberships for all the participants in the program. And it's been, knock on wood, extremely successful so far. I think as with Boeing, we're all kind of early in the journey here. The early indicators are extremely favorable, but I think there's also a little bit of humility required, as I think the gentleman referenced before, because even though the data may look great and everything else, sometimes well-laid plans can develop in unexpected ways. So that's my story.
Well, thank you all for being here. I think we have all sorts of different employer perspectives to share, and that's great because this is something that's open now to so many more employers than it was before the law was passed. Dylan, I might start with you with another question. As we were preparing to have this discussion, we talked a little bit about affordability. Could you address how these changes will really help employers address the affordability crisis for themselves, but also for their own employees?
Yeah, so we can't get away from the context of anticipated increases in healthcare spend into next year. Our own survey comes out in a few weeks, but there are other surveys that have come out recently from some consulting firms, predicting higher healthcare cost trends than in over a decade. And that is very much top of mind in almost any conversation that we're having with our employer members. My boss likes to say that, we all say healthcare cost increases are unsustainable, but we've been sustaining them for 25 years. So it's not necessarily that they're unsustainable, but they're, let's say, unacceptable. And they've also come to the conclusion, rightfully so, in my estimation, that cost shifting to employees is not really tenable anymore. I think the conversation that we're having with our members is far more about how we can reduce the cost of care in general, but also specifically for employees so that they can get access to the preventive services and the primary care that's going to keep them out of the higher cost settings and higher cost conditions, whether that's a individual claim or a chronic condition. So this is, a great opportunity to be able to get people into direct primary care in a way that is not going to require them to totally, kind of change course with their insurance model. We do have about 45% or so of our members who have on-site and near-site clinics, and only 11% right now who, as of 2025, according to our survey data, are implementing DPC partnerships in some way, and that could be in one market. So it's relatively nascent for our membership, but the opportunity to decrease overall costs by keeping people out of high cost settings and also make care affordable for people. I will say too, the Preventive Services Task Force, the kind of uncertainty around what's going to happen there too, I think the ability to get access to primary care where you're just going to get that preventive care. It's built right in, is going to be a huge benefit too.
It's a game changer for sure. Linda and Dave, maybe for you, could you talk a little bit about how you look at direct primary care and measure success? What does it mean that you've implemented a successful model? What does it look like for you as the employer, but also for your employees as well?
For us, I think the one of the driving forces behind our strategy is addressing access. And so having a solution where people not only will come and use it, but they'll use it again and again instead of the high cost settings. In the past, our high deductible health plan members primarily were using urgent care because they didn't realize spend the money, so they waited till they had an issue and they'd use urgent care. And anyone who's been in an urgent care setting, and I don't mean any offense by that, you're paying triple, maybe double, triple what you would pay in a primary care setting at a minimum. And so for us, it really is about access, making sure people get in a reasonable amount of time, in most cases, same day, next day. We don't refer to primary care as virtual or in person. We actually stay away from using modality as a description for care. But we also recognize that modality is a key feature of getting care when you need it on demand. For our direct primary care relationships, our number of virtual visits is it ranges anywhere from 18% as high as 37% of all visits are virtual care. And I'm talking just about medical care. When we look at our non-DPC arrangements and that use, it's around 4%. And so it's I think part of it is making it easy, but again, it's about creating a relationship with a team, with a care team that makes it easy for access. The other things that we'll be looking at down the road as we get more data, more people involved, is really what we're seeing in terms of usage behavior. Are people still using the high cost settings? Has that started to shift? Has that started to change? What's our preventive screening rates? And it's not just preventive screening, it's also blood pressure management, it's diabetes management. Is that something that's actually going down or going high? Is it better with our DPC members than our non-DPC members? So these are some of the areas that we'll be looking at to measure success.
Yeah, so I think I have a little bit of a different perspective on it. And, for all the employers out there, I would just encourage you to think about DPC as a longer term investment. And I think you need to look at it with a bit of a longer time horizon than perhaps the one policy year that most people, the lens that they look through. And, one of the things that we've seen is that quite frequently when you implement DPC, you find that utilization actually goes up a lot, at least in our groups. As you say, okay, and the plan design matters too, so don't get me wrong. It depends on, what the incentives are and all of that, but just all else equal, when you introduce DPC and the access that it affords to all the members, we find that the person who maybe hasn't seen a doctor in 10 years realizes that they have high blood pressure now, or they're pre-diabetic, or perhaps they have a substance abuse issue that they haven't been comfortable talking to anybody about that they're struggling with. And so, a lot of times what we are seeing in our groups is the spending actually goes up in the short term. And so I think I want to make sure that we put that on the table to say, hey, in the short term, if spending goes up, that could actually be a success, because you've got all these people with deferred care that have been waiting and bottled up, and they haven't done it and they haven't addressed it for a long time. And then you're giving them this primary care and they say, oh my goodness, okay. And of course we all believe in DPC and we know the magic of it, and people believe their doctor and they have the relationship and all that. And so what we typically see is there's a huge build, in the first 6 to 12 months where people are getting all of that care because of the access, that they're afforded. And then the wave crests and falls off. And so in years 2, 3, 4, and 5, you have these people that are not being admitted to the hospital because they're not having the stroke that was addressed in year 1, and those kinds of things. So I think that that's an important thing to identify and understand and recognize as an employer, is that you actually want utilization to go up. I think the key thing is you want the utilization in the right buckets. And I believe we all agree that primary care is where the action is. That's what you should be putting all of your efforts behind, in my opinion.
Now, you bring up a good point that there are some challenges to this, but even if there are there's delayed care, right? There would be delayed care if you didn't implement DPC. Now your workforce is actually getting access to the care and getting healthier, and that's a good thing for everybody, right? Yeah. Maybe Linda and Dave, let's talk a little bit, kind of the other side of the coin, some of the challenges or the barriers that you've seen in terms of implementing DPC. And Dylan, maybe you could share from your vantage point more broadly, just what are some of the barriers for employers that maybe aren't doing it yet? What have they seen? Why is that they haven't? So maybe Linda and Dave, maybe I'll start with you first, and then Dylan. Do you want to go first on this one?
Sure, I'll try to keep it brief. In my experience, it's mostly financial, I think. And so you talk to an employer and they say, hey, I've been on the wrong end of a 10% increase for 15 straight years, and so now I'm paying $900 a month for a single, and here you are trotting out this DPC thing that, forgive me, to some folks sounds a lot like wellness, which has been kind of a mixed thing in the industry, and they say, no thanks, I've just been getting killed every single renewal, and now you're telling me I have to spend an incremental, $70 on top of this, giant increase that I'm observing here. So I think that, from my perspective, that's the biggest driver, is that we've got to find a way to encourage the payers out there to say, hey, DPC is actually displacing this primary care piece, So in a traditional insurance arrangement, unfortunately, you don't get the benefit of that, because the carrier has it laid in there as, 7% or 8% or wherever the actuaries tell them. And then the decision maker says, okay, I'm not getting any credit for that. And so now I have to spend an incremental $70 for a DPC membership. So where's the return? Now I think we probably all would agree that the return is still there, and in my humble opinion, it absolutely is. But you can be forgiven for a person who doesn't really understand or know what DPC is or what the promise of DPC is and not familiar with the data. They look at it and they just say, I got a budget, and my boss is telling me, get the number down, get the number down. So they probably don't want to hear about, well, I want to spend an extra incremental, 10% to get DPC for our folks.
I think that's a really good point. I think for employers, I think there has to be an acceptance that there is going to be an investment up front. And I completely agree with you that this is not a short-term strategy, nor is this a product. We don't think of DPC as a product at all. And so I think that when I talk to other employers, the other thing that comes up is they tend to delegate this type of work because they have small teams. And so they tend to delegate this to their health plan. If their health plan is not positioned to pay differently for primary care, and I'm not aware of any that are doing that, although we're pushing them, then that kind of, if they don't rethink this, that's going to leave them out of the game, if you will, out of the right direction and the right solution. So I think that's another thing that we commonly hear. And I said already that the whole HSA rules around deductibles, that has been a big administrative burden, not just for us and our partners, but it also has been, despite our efforts at communicating, it's still more affordable for our high deductible health plan members. It still doesn't resonate with them. Imagine in a new year when I can go to them and say, all those in our high deductible health plan, you can use the DPC clinics at no cost to you. That's an entirely different conversation, and we're incredibly excited about it.
So I'll echo my fellow panelist points. So the incremental increase in cost early on is going to be a challenge for some employers, and maybe the people in HR get it, but the people in finance might not get it. I don't want to discount the kind of communication challenges. But Linda and I were talking about this in the corner over there, that I've got smart friends who call me and ask me basic insurance questions during open enrollment. So just the kind of consumer or employee education there. Another thing is just when you tell people you get something for free, a lot of the times they immediately go, well, what's the catch? Why are you trying to get me into this DPC? It sounds too good to be true. So there's some kind of communication and change management that's going to need to be in place for it to really take off.
Wow, but the Primary Care Enhancement Act means that we have that opportunity to do that change management, all that education and the communication, both for employers as well as for employees as well, and that this model of care has a opportunity to really blossom and take off and scale nationwide. So just in the last minute or two that we have, could you all just touch on what you see as the future, how you see it in the next 2 to 5 years, and what you're hoping for?
Why don't you go first?
Well, I'm hoping for a lot of people, a lot of our employees, to understand what direct primary care means. It is probably, since I've been with Boeing for 10 years, the number one item that comes back unsolicited, favorable comments. We get emails all the time from our employees who experience it. We've had people volunteer to do testimonials. We had one member who actually went to the DPC and said, "Can I do a testimonial for you?" The feedback we get on this experience is extraordinary. So the future is, how do we make it easier and easier and easier for people to use this model? The other side of the argument, how do we ask more and more of our DPC partners? I want our DPC partners to be making the decision on what point solution we're using, not necessarily another team. One of the things we tend to do as employers is we're filling gaps that our current primary care system has sort of left. And so we've been paying for that failure to a certain extent. But we've also done things that are competing with the experts we're partnering with on DPC. We want to see DPC own more of that direction and what really is going to benefit their members. That would be my vision.
Yeah, I think one thing that I would be very grateful to see is if within the DPC movement, I think that there's a little bit of hesitation and concern about bringing on employers as clients. And it's a totally, in my estimation, totally valid business logic to say, hey, if I've got a panel of 400 patients and 150 of them are locked up in one contract, with one party, and that goes away, that's a pretty significant dislocation, for a doctor. So I totally get it. It's absolutely rational, very logical. But I think I would just ask that the movement at large become a little bit more receptive and open to, hey, employers, in my opinion, are really where it's at. It's going to be very, very difficult, in my judgment, to continue to have this block by block battle of converting one patient at a time and going to Chamber of Commerce meetings and doing all the things that DPC doctors do, which I applaud and I think is wonderful. But I also think as a business person, sometimes you got to find a way to be a little bit more efficient, in terms of acquiring your customers. And so I would like to see a little bit more discussion and openness to, hey, can we find a way to balance, the concentration risks associated with having an employer as a client if you're a DPC practitioner, with the recognition that, hey, most people get their health insurance through their employer. And so like that's just a reality, and we're in Washington D.C., so who knows what could possibly happen in the future. But I think that we need to plan for that to continue to be the case. And so I think that everybody who's invested in this needs to try to work together to say, how do we make this as good as it possibly can be for our employers? And that goes for everybody. It goes for the DPC practitioners, it goes for the employers, it goes for the financing mechanism, everything, all of it. So that would be my humble suggestion.
And briefly, I would say that I hope that the model grows quickly. There's a lot of uptake amongst our large employer members. I think there's a lot that they have to figure out. Linda mentioned point solutions. There's a very big vendor accountability discussion that we're having with our members right now, particularly as costs are rising, figuring out what's actually working and how are the point solutions that you have working together, which is very difficult to suss out. And there's an opportunity to make the system a lot smoother and make a lot more sense for employees if they can get into DPC, and opportunities for kind of right-sizing other parts of the benefit strategy. But it's tricky, and the timeline that our large employer members are working on for their benefit strategy is often 2-3 years in advance. So this allows us to change the conversation, and I'm hopeful.
Well, it's an exciting time. I want Dylan, Linda, and Dave, thank you so much for sharing your insights with us today, and we appreciate your time here. I'm now going to turn the mic back over to Sarah and our next panel of physicians.
Thanks so much. That was really powerful to hear from you all.